Good evening, everybody. My name is Margot. I am the marketing director here at the Root Center. Before we get going, I do want to just get some housekeeping items out of the way. Phones, I know we've all got them. Just please make sure that they're turned off to silent. And for the folks on Zoom, please make sure that you're muted. If you do have your phone, though, we appreciate any photos. We are on social media, all platforms, Instagram, Facebook, Twitter, and LinkedIn. So if you snap a photo, want to share your opinion, let us know. You can put it on those as well. Also, we have two exits, one at the front and one at the back. So in the case of an emergency, you can go to the one closest to you. The staircase is located right at the exit at the end of the hallway, and the bathroom is out in the middle as well. We also want to let you know there's plenty of food over there, so help yourselves. Hopefully you got a pen and a note card in the beginning. I'll be passing around a basket later. You can always ask a question by raising your hand, but you can put one inside the basket and we can bring it up to Dr. Podolsky later on during the presentation. So this presentation on safe injection sites, it is our community forum, one of our first that we're putting on behalf of our Advanced Recovery Institute. It's a new entity of the Root Center for Advanced Recovery. It's committed to research and training, all to elevate clinical care. And of course, this is a hot button issue. This can get controversial, but it's one that we feel is necessary to have. So we've collected a group of panelists who have many different backgrounds. We'll be able to spark conversations and hopefully thought-provoking ideas that can go on to better serve the recovery community and what we need to do to help others. So without further ado, I will introduce now our Chief Medical Officer and moderator, Dr. Joseph Podolsky.
Thank you everyone for being here. We've really put together a dream team panelist group here. So I'm going to have them introduce themselves kind of one by one so that you can get to know who's here and why they're here. So I'm going to ask them to kind of tell us a little bit about where they're from, why they thought it was important for them to be on this panel. And I think that'll help you realize, who you have in front of you and help gauge questions to help engage the audience. So first up, Peter Canning.
Hi, yeah, thanks for inviting me. My name is Peter Canning. I've been a paramedic in Hartford since 1995. When I started as a paramedic, I did some overdoses, and I thought people who overdosed had a character flaw. And I would say to them, "What are you doing? Just stop using. You're going to end up dead or in jail." As the overdoses started going on, I started looking around me, going, "Well, what's happening here? They're really increasing." So I started asking my patients how they got involved with using opioids. Once I started hearing their stories, I completely changed my tune. I learned about addiction, something that paramedics are not taught. So in time, I became very involved. I learned about harm reduction. I got to know Mark Jenkins. And my goal now is to take the EMS, all the EMS people out there, and deputize them into the harm reduction movement. Last year, I wrote a book called Killing Season, of paramedics' dispatches from the front lines of the opioid epidemic, in which I took my patients' voices and the lessons that they taught me, and I tried to write about them to share them with the public. And I have a chapter in there advocating for safe injection sites.
Thank you very much. Next up is Dr. Stephen Wolfe.
Hi, it's a pleasure to be here, and I would recommend Peter's book. It was an excellent read and gave a very accurate sort of overview and synopsis of what's going on in our community, but which is the same all over the country. I recently retired from St. Francis as chairman of emergency medicine. I was chairman for 15 years. St. Francis has always been very much in the forefront of substance treatment. After the Yale article in 2015 about starting Suboxone in the ER, we were the second after Yale to start that in our ER. And I would say it was met with some resistance, but it gave physicians a chance to actually start treatment in the ER, as opposed to just say, yes, you have a problem, and now we're going to sit here and wait a while until we find a spot for you. So that gave us another, just like dealing with strokes and dealing with heart attacks as time goes on. We were able to do something about strokes and heart attacks, whereas before, in the early 80s or 90s, we would say, yes, you had a stroke, yes, you had a heart attack, and admitted you to the hospital, and not a whole lot we could do about it. Besides the ER work that I've done, I'm also on the board of Intercommunity. I'm also on the state medical board and do a couple of other things with Hartford Police and a couple of other entities. So semi-retired, but not fully retired. And I'm glad to be here because I think, you know, what we're trying to launch in terms of the safe administration sites, or whatever terminology you want to use, is I think a very important step. And it's just like gun control, not one answer works. And hopefully this will be one other piece of the treatment puzzle.
Thank you very much. Next up is Lisa Peterson.
Thank you. My name is Lisa Peterson. I am the Chief Operating Officer at VICTA in Providence, Rhode Island. We're a multi-specialty agency that provides opioid replacement therapies, as well as substance use, mental health, psychiatric services, and ambulatory medical care. I'm also, in my spare time, the co-founder and co-chair of the Substance Use Policy Education and Recovery PAC. So I've been fighting for safer consumption in Rhode Island for the last several years. It finally passed last year. We'll be the first state who has completely sanctioned these sites. And I'm excited to be a partner who is working to actually open one within our organization as part of our continuum of care. So I'm here because I am passionate about all things harm related. It's what I'm living and breathing right now. The stat that I have used to drive home the importance of this is the first time I testified on this bill 3 years ago. Between that time and the time that it was passed on the House floor, over 800 Rhode Islanders died. So that's continued to grow. Over the last 2 years, we've seen surging overdoses after a period of really making some progress. So obviously the COVID-19 pandemic has amplified that, as has the dearth of behavioral health providers. So I just think this is the most sensible thing, is to save lives and offer them opportunities to re-engage with the community.
Thank you. Next up is Pat Reamer.
Hi, good evening. I'm Pat Reamer. I'm also newly retired. Very happy. But prior to retirement, I was the president of the Behavioral Health Network at Hartford Healthcare. And prior to that, I was the commissioner of the Department of Mental Health and Addiction Services. And I would say that I very much learned about recovery while I was working at DEMAS from people who were in recovery. That was absolutely where I learned about it, and fully believe that people can and do recover from all mental health issues. I think it's really critical. And I've watched the legislation over the last 10 years, you know, that started. How many years did it take us to get Narcan available so that the public could use it? And if you listen to people who are standing on the floor, they would stand up and say, you all know this, right? I don't have anything against those people that use drugs, but, and that's how it got killed over and over. But we did prevail, as you know. And so we've made some progress in this state. I feel like we're a very well-funded state from a per capita point of view. Actually, our Department of Mental Health and Addiction Service is the most well-funded state agency for treatment in the country by far, by far. So I think they provide the leadership to the private nonprofits. I think the private nonprofits push the state agency to make sure that they're staying up to date. And I think the partnerships are terrific. I do believe, as many people do, that you can't recover if you're dead. And so just like Narcan and the controversy around that, I believe that safe injection sites are really part of the harm reduction and save people's lives, save people from things like communicable diseases, and really decreases the incidence of overdose. And so it gives you an option. And I really also believe, by the way, that if these are staffed with people both in recovery and clinical people, but primarily people in recovery, we have a really good shot of moving people on that continuum closer to recovery. So I'll stop there.
Thank you. Next up, Alina Khan.
Hi, I'm Alina Khan. I'm a second-year student at the University of Maryland, so not really from Connecticut, but I'm studying sociology and environmental policy, so also not really public health. However, when I was in high school, I was in a YMCA program called Youth in Government, and it was a mock government program at a state and national level, and we would write legislation and debate it and pass it in our mock legislative sessions. And so one year I was trying to come up with something or find something that I had never heard of before. And I stumbled upon safe injection sites. And ever since I heard of the concept, I fell in love with it. And so I wrote mock legislation for it at my state conference and then at a national conference where people from all over the country debated it. And then when I got to college, I joined Combating Overdose in Rural Areas, which is a club that basically we would go to different areas in Maryland, collect data, come back and use that data to create resources for people in communities, rural communities that need information on, overdose prevention and what is overdose and things like that. And then I also joined a student newspaper, and I was really interested in public health and harm reduction and things like that. And so I joined the health section of this newspaper, and I wrote an article about safe injection sites, and that's what brought me here.
Thank you. Sam Rivera.
Good evening, everyone. I'm Sam Rivera. I'm the Executive Director of OnPoint NYC. I wrote "Wow" here. This panel is pretty cool. I want to sit over there and just listen for a little while. I also want to retire, so I hope that happens soon. So I'm the Executive Director of OnPoint NYC. I've been doing this work for a very long time. I don't like to say because then I sound really old. This work is big for me in many different ways. I grew up in the Lower East Side of Manhattan in New York City. Apparently I have a New York accent, so you might hear it. And so I grew up really in what people call a drug war, and I call it a war on drug users. So this work is really deeply embedded in my life. Why am I here? Well, I'm running the first 2 safe consumption sites, not safe injection sites, but safe consumption sites. I can talk further about what that means in a little while. And if there's anything I can do to support people as the guy running the first 2 in the country, I want to get out as much as possible and support. And if there's anything I can do to help people open and do it the right way, I want to do that too. So it's truly an honor to be here. I really appreciate, also like to drive up. It was pretty nice. So it's really a pleasure to be here. I'm looking forward to sharing what's happening with all of you.
Thank you, Sam. So we also invited Mark Jenkins to be on. He's the Executive Director of the CT Harm Reduction Alliance. He had to go overseas last minute, so he was going to try to get on virtually. Mark, are you on? Otherwise, I think we'll just kind of move forward. So go ahead.
And as an additive, we do have a former patient of ours who was successfully discharged from our New Britain clinic. She's just running a little bit late leaving work, but she will be here a little bit later on. So that's coming up too.
Great. So I thought I'd start off with Sam Rivera, and I have a few questions for him. So we'll get started with that. But for someone who doesn't know what OnPoint does, what is it?
So OnPoint NYC is a full-fledged harm reduction organization. We provide an array of services from case management to housing assistance to we have low threshold medical services. We offer holistic health services, which is really something many of our folks and people in recovery and people who use drugs don't have access to. All these services are free. And those services include acupuncture, acupressure, sound therapy, a lot of options in that health way. We're also are developing a food and nutrition program, but in the interim, we are offering healthy meals to everyone who comes in. And of course, we have the safe consumption sites. We have 2 of them. We have one that's considered the peer model and one that's considered, please remember that, important, the medical model. We could talk further about that too.
Sure. So if you could walk me through what it looks like when somebody enters your facility.
Sure. So the perception is you open the door and there's a drug using orgy, like everybody's just, I say that right? I said drugs. Everybody's just, you open the door and there's a bunch of people using drugs, and it's not that at all. When you open the door, you're going to walk into a room about this size, maybe a little bigger, with people watching television, watching a movie, having a meal, using a computer, meeting with a healthcare professional or mental health professional. A number of things, talking to each other, sometimes loud. So that's happening when you first walk in, and oftentimes when people come visit, they're like, wait a minute, where's the drug use? What happened? So then in the rear of our drop-in center is a locked door, where we have our safe consumption site. So when someone comes in and they want to utilize that space, they go through a series of questions. We ask them every time. Of course, if you've been coming, we ask less, but there are some very important questions we want to capture, especially because we close every night right now. We're not open 24 hours a day. So we ask things like, what are you using, how much, how? So we know what that's going to travel into the room with you. If you weren't here, what would you be using? Very important. Did you have any police contact? Things like that that help us not only work with the individual, but work with the community to address some of the concerns or some of the information that comes up during that assessment. At that point, when there's a booth available, depending on what they're doing, what they're using, and this is why we say safe consumption. People smoke as well. So it's not just injection, it's smoking as well. So we have in our Harlem site, an older group, an older population, many who smoke more than they inject. And then in our Washington Heights site, we have a younger population, many who inject more than they smoke. So in Harlem, we have a large smoking room in comparison to what we have in Washington Heights. So someone comes in, they enter the room, we already know what they're going to use. That message is brought into the room. They go to the rear, they use a pedal machine to wash their hands, so not touching anything. Once they do that, they go over to the section where we have all the paraphernalia they need, depending on what they're using. They get what they need, and then a staff member walks them over to, let's say in this case, a booth, and starts talking to them about, just checking in, seeing how they're doing, and then they start to use drugs they brought in, not drugs we offer. Sometimes they'll ask us to test because fentanyl is rampant. What we know is everything we test has fentanyl. And so right now we're testing heroin to see if it has heroin. That's what's really happening.
And give me an idea of who's coming to your center. I mean, you're in Manhattan, so I'm assuming there's a lot of people that live there, but is there anyone that's coming?
So it's interesting. When we first opened, we were worried. The local community was worried about people coming from outside, and they're taking the brunt of it, that everybody's coming to Harlem. What we know about drug users is very few buy in one place and travel all the way somewhere else to use. They normally buy where they're using and use it. But one of the things we had to look at that was very interesting was that people were giving us addresses they remembered, right? Like, so where do you live? So yeah, I don't know, here's Queens. I used to live in Queens. I remember the zip code. And so we have to spend a little more time with them to make sure that they're giving us the true, at least an idea of where they're staying. Even if they're in an encampment in Harlem, in a park, we want to know that so that it doesn't look like people are traveling from all over the place. We had 2-3 people from Connecticut. I'm like, did you come here from Connecticut? Yeah, 5 years ago. So yeah, mostly primarily local folk who are coming in, people we've known. We're not getting many new people. These are folks we've been working with for years. One of the differences is we're getting people from encampments and people that our outreach and public safety team would meet out in the street. So they're coming in. But yeah, we're getting an array of folks who've been in recovery for years, many people who are talking about how COVID took them out of recovery, people who are in recovery for a long time and relapsed during COVID. We have 2 or 3 couples who come in who fell into it together and started using it.
So New York City is the first place in our country to have a safe injection, safe consumption site. How have you been accepted in the community?
So initially, and I respect it. I'll tell you this. I respect the concerns and what it sounds like. I mean, think about it, right? Sam's letting people come in to use drugs. What I told the community is I answered their request. And they're like, we didn't make a request. I said, you did. You said you didn't want drug use in the street. You didn't want drug use in the parks and in front of your children's schools. You didn't want syringes and paraphernalia everywhere. And I responded by having them come inside and use it with us. We want it. There's a joke I say, I'm guessing many of you saw this movie where they don't want Bruno. We don't talk about Bruno. We want Bruno. Bring Bruno in. Right? Most of our people fall into that category. Like the person in the family people don't want to identify or talk about. We want them. We want to love on them. We want to show them and talk to them about who they are, why they use. I ask people, why do you use? And they say, I'm a junkie, I'm a loser, I'm lazy. And we spend time talking about, no, why do you use? What's in your core? What pain are you self-medicating? What mental health issue are you self-medicating? Let's talk about that. So you can get a better understanding as to why you use and then see yourself in a different way. Yeah, that's what we're.
Has anyone ever said, you're enabling addiction or
All the time.
enabling people with addiction?
Yes, yes. Often, yeah, they're saying we're doing that. What we know is, I'm sorry. Go ahead.
No, and this can be just kind of a general question too
Oh.
for
Yeah,
everybody,
please.
but please feel free to chime in.
I'll wait.
Around that issue where there's a belief that comes from somewhere that suddenly people will start using drugs for the first time ever because we're offering them a safe space. It's just not borne out by the evidence, but there's this belief that I'm going to start injecting fentanyl because I can now. Or yeah, certainly even some folks in the field are still grappling with this and sort of have a theoretical understanding, but in their gut, it feels like we are enabling, but really all we're enabling is for people to breathe and live another day. So that's kind of my trite response to folks who raise that concern.
Now, how do you liaison with medical personnel? We have, medical personnel here. But, at a safe injection site, what is kind of the ideal situation that you would have in order to, deal with folks that might overdose, or how do you engage them with medical issues that might be there, nutrition issues that are likely possible, things like that?
I'll start off only because I hope somebody else jumps in, but 324 overdose interventions, 5 calls to the ambulance, 5. In New York City, that's 324 calls to an ambulance, which includes a number of police officers, plus the ambulance drivers, EMS folk here, their time. If you go to New York emergency room, basically the whole thing is about $30,000 roughly. We've called 5 times. None of them had to do with the overdose. They all had to do with other health concerns. Other health concerns we were worried about after the overdose. Not even, they didn't all have overdoses, sorry. And only 2 left in the ambulance. So that relationship with our local ambulance, who was visiting us 4 or 5 times a day, is now, they love us. They come in and have coffee instead and use the restroom. They're not coming like they used to. The local ER loves it. People in the community really who had hesitation about us opening are truly now having to surrender and say this really works. But on the medical side, it's been a pleasure to have that relationship with our EMS folks and medical providers change.
Talk a little bit about that in Hartford. So in Hartford on Albany Avenue in the north end of Hartford, people talk about using drugs in safe or public consumption places. So it's not uncommon for me to get called to the subway where somebody is trying to get in the bathroom and it's locked. Somebody's been in there for 20 minutes. So by the time we get there, banging on the door, the fire department has to open it. We try to push the door in, but somebody's behind it. Some people have died in these places. At McDonald's in Hartford, a lot of these places, these are in public. People are dying because law and stigma drive them into the shadows, drive them behind locked doors. Now on Albany Avenue in Hartford, there's another place called The Drop. What happens there is they have a bathroom and people come in and they use that bathroom. And they go in and after 3 minutes, what they do in that bathroom is their own business. But after 3 minutes, someone knocks on the door and says, "Are you okay?" The door opens out rather than opening in. And there have been some overdoses there. By the time I get there as a 911 person, that person has already received naloxone and is back. In some cases, we take them to the hospital. In other cases, they'll stay there and they'll watch them. Sometimes they might not want to go to the hospital because they're worried they're going to miss an appointment somewhere. But the person at the drop will call that place and help them out. But it's a wonderful place. And I'd much rather have somebody using there than under a bridge or behind a locked door at McDonald's where we find them. The people that I call the time on that are dead, they die for 2 reasons. They get fentanyl, which they cannot judge the dose, so they have no idea how much they're getting. And they use alone. They use under bridges, locked doors, and in alleys. We need to bring these people back into our community in a place where somebody can keep them alive. And as he said, that people don't die in these places, and they can get help and they can get love, and that's what they all need.
Question, the big, I mean, I'm thrilled, just so thrilled to hear that, but how are we gonna fund it, right? And that's where we have to, in my opinion, sway the public's opinion, because otherwise we're not gonna find a way to fund it, right? And this will be something that has to really be evaluated. Is the state gonna fund these places? I personally think they should, but I'm wondering who funds yours?
Yeah, Sam, how do you get funded?
Unrestricted funds, fundraising. There's no money I can use. I had to create a separate bank account to prove that I'm paying staff out of that bank account only who are working in the OPC. We call the Prevention Center, a safe consumption site. So we had to use donations. We have a couple of foundations who have stepped up recently. We will be hopefully putting that information out there to celebrate their support. But yeah, it's scary. I'm reaching a very scary point. As much as I would like to see others open, I see if more open, we'll be fighting for the same crumbs and asking people to support us. I'm not allowed to use any money. And believe me, I've been audited already, so I'm happy to say that we're doing it well. But I agree. What we have in the country is a crack-out statute. The crack-out statute was created by Biden. Very happy about it many years ago. I've reached out to him a few times. I'm going to Washington on Sunday. Hopefully we'll connect. But he was proud to create the crack-out statute, which makes what we do legal, federally, which also doesn't allow local, city, state funds to be used. We do have the state New York pushing hard to pass a bill to fund us directly. And people are really seeing the differences in the impact. So we're getting a lot of people stepping up for us. Many people who lost family members who know if their family member was in that room with us, they'd be alive. So people are donating. But yeah, that's the biggest, toughest one. The blessing is marijuana. And marijuana showed that you can pay people. You as a state can help fund something by breaking the law with us. How about that?
Stephen,
Well,
so-
it may be that funding that we're gonna get in the next year or so could be effective,
Oh, yeah.
right? That's-
So we've got a question from our CEO, Stephen Zuckerman. Go ahead.
Yes. Of course you would ask.
It's not Connecticut.
So,
Steve.
yeah. So there's a few things. That's a great question. Of course you would ask that. So one is money, one is your landlord, one is it's all of that, right? So for us, we have two great landlords, and I did a thing called the leasehold condo. So it looks like we're buying the place. I did that intentionally so the landlord loses power. That was just a little slick thing I knew from some history and research. But yeah, your landlord has to agree. That's a big one. Oftentimes when people try to open one and community members don't want it, they go right to the landlord. And so you're going to allow this in here, it's illegal and all these other things. Money, but the money's the big one. You're right, money's the big one. They should get a blessing, in our case, from the health department, from the mayor. I don't think anybody should just open. I can tell you this, New York harm reduction providers who want to open are following our sort of own creative guidelines. Don't just open tomorrow. Be careful. We don't want to get in a position where then we close because someone else opened in a bad way. And I'll say people have called me and said, can I have your policy and procedure? I want to open. It's not that easy. Yeah, there have been a lot of lessons. So this is one of the reasons why I like to go out and talk to folks. And also, if you're thinking about opening one, visit. You really should.
How did you get around the crack house statute?
I didn't. And it's a good question. I'm currently conducting an illegal
So
service.
the feds just aren't.
The feds are being nice.
Right.
They have peeked in. I will say that. I can't say much more about that, but they have looked in, and we're shocked to see how we're doing it. Really shocked. They expected the same thing. They expected this madhouse and no structure. They were blown away. The big concern now is regulation. I think someone said, who would regulate them? Where would you get the money? what does it mean? I said, I would love to be at the table when you create those regulations. You know, we're doing a good job. So I'd like to be involved in the creation of what that looks like.
And in Rhode Island, we did, part of the legislation was to have the Department of Health promulgate the regulations. So we'll be licensed by the Rhode Island Department of Health. And in terms of medical involvement, we were very fortunate to have the director of the Rhode Island Medical Society as one of the biggest voices championing this legislation, as well as the heads of the Rhode Island Department of Health who really prioritize this. So in comparison to other types of licensing, it's a pretty straightforward process and they're not putting up undue barriers, but they are making sure that it's done right and that there's some oversight, inclusive of mandating that safer smoking be included in any site so that we're not leaving anyone behind.
I think it really depends on the site. I was reading an article about Philadelphia. They were trying to open a supervised injection site or whatever you want to call it. And so a lot of people in the community were not happy. And so they pushed it in the courts. And so the Third Circuit Court struck it down. So it's illegal in the area of the Third Circuit Court, but the Supreme Court decided not to take the case. So technically everywhere else, there's no court case that's saying, I mean, there's still the law, but there's no court case that has struck it down. But in the Third Circuit Court, where that Philadelphia site tried to be created, it has been like shut down there. So.
Yeah, we have Saud Anwar here. He's a pulmonary critical care doctor that I've worked with for many years and also a state rep. So there's a complication between, you know, what I would call regional or state law and then federal law, and the crack house statute precludes you from getting any kind of federal funding. But it seems like a lot of states are pushing forward with this. And I'm wondering, has the political landscape changed for you?
Well, I wouldn't have tried this a couple of years ago. There's no way. I mean, I have no problem saying it. I wouldn't have. It was just, you know, we didn't know what was happening. Interesting enough, that administration did some stuff around overdoses, but they also stopped Philadelphia from opening. There looks like some good news coming from the Safe House case. We're feeling pretty positive about it simply because they keep pushing the announcement. So to me, that's clear that they're worried about what they're going to say, especially before November. So yeah, we're in a very interesting time around funding, but it's really a blessing to see so many states stepping in. And in New York is very interesting because New York City is basically much larger than the state itself. But the state is stepping up in a variety of ways and looking to see how they could fund this directly.
So I just wanted to thank you for all you're doing and the organizers. For the past 4 years, every year we've had an opioid-related bill. I'm currently a state senator representing the 3rd Senate District and currently the acting chair of the Public Health Committee. And this is something that each and every one on our committee is very passionate about. And whenever we have had an opioid-related bill, after appropriate conversation and education, we pretty much had 90+% of the legislators support, and sometimes unanimously as well. This is very interesting and exciting to me because in the intensive care unit, I see the failure because we're seeing deaths or brain deaths when somebody is not receiving the treatment. It's a common sense approach, and common sense approach is the smartest approach. Now that you're not the first ones, and you probably have enough data, this is going to be a very important conversation for us in the next session. So I will be talking to some or all of you, my friend as well, and teacher. So we'll look forward to learning and looking at the research of the bill that we will.
In terms of data, just to quickly weigh in, Brown University is partnering with both New York and our sites to measure both sort of approaches. And so they will hopefully have some data within probably 2 to 3 years. Obviously, we want to have things move sooner than later, but it is already in progress and will be coming.
Is there any regional political collaboration between Connecticut, New York, Rhode Island? Sometimes that happens.
Yeah, the governors actually specifically around the issue of opioid overdoses certainly got together historically. I'm going back because it's been 6 years since I was there, but I know that the governors did meet about that. So, and I think that that's something that the governor would be open to talking about.
We have next to our Attorney General the opioid settlement fund. And this year we've made sure. Thank you.
This year, we have made sure that the opioid settlement fund would only be used for opioid-related prevention and management-related responsibilities that we have to the public. This falls squarely in that realm, in my opinion. If anything does, this is it. So I think to get something up and running, the state and the towns and the community have to be partners. But the state has a role in this because we are just from the unintentional, these are the unintentional overdoses from fentanyl. We lost 15,000 plus people in last year. So we have a huge responsibility to be able to be partners in identifying those solutions. But the money should be able to be looked at seriously as we move forward in this.
And Dr. Anwar, what would be the next steps? Walk us through some of those.
So
details.
the next steps would be that we need legislative champions, and I can tell you there will be a lot of them because this is personal to many people in the legislators. It's not one party versus the other. It's a human issue. It's an issue that touches each and every one of our lives. So at the next legislative session, when we start in January, we'll probably have between now and then multiple conversations. In November, of course, people have to get reelected, and at that time, we will start to make a legislative strategy and have discussions and have public conversations and even make sure that the rest of the state learns about the experience many people have had. And then we start to put our thoughts together. The committee that works on this would be the Public Health Committee. And irrespective of who gets elected, whoever is going to be there, we will make sure that this becomes one of the top priorities to save the lives and have an approach. And that's what we'll have to look at. From a state point of view, that's what we'll have to look at. The part about the town ordinances and how the planning and zoning component works, that may be a hurdle. And then that's a planning and development committee. That's a separate committee. Maybe there'll be two bills to try and work on that because we need to identify ways and probably provide incentives to the towns to provide this and then have areas where it could be effectively used without impacting the property values. And that's what is very critical to individuals. So I think we will have to start to think about how do we educate the community. And then frankly, some of the places, just like you alluded to, if somebody's out there on the street using a drug versus in a safer environment, what would you prefer? It's going to be a safer environment. So smarter things would be that in some of the communities which are seeing their loved ones being impacted and people dying, there would be an easy sell there. But this is a phenomena that is not restricted to any city. It's in every suburb, every town. So it's unfortunately somewhat of an equal opportunity employer across the different spectrums of our society. So we want to make sure that communities use it in the same manner, in a respectful manner in every area where they are worried about this.
Couldn't be here tonight, is to start to form a committee of different individuals in the state of Connecticut to be able to start to talk about how those opioid settlement funds might look like and how they would look like for services specific. So I know Brian and we just submitted a letter to Commissioner Navarrete to be able to get on that committee. So Root can certainly be part of those discussions. So I think, as Senator Anwar said, I think this is a perfect opportunity to be able to push that as one of those things.
Thank you. I know the planning and zoning thing I know has come up a lot when I've reviewed this topic online, but I know you ran into it even in Harlem. So I'm just curious if you could speak a little bit about that. And then if anyone else wanted to chime in, that would be great.
Yeah, in Harlem, a couple of things happened. It was really, most of it was miscommunication. So I just want to be clear. We had one protest specifically about us, which was, I think, 4 people and a dog. And then there was this other sort of protest that was about the oversaturation of drug treatment programs in Harlem. We got bunched into that. It had nothing to do with us. When I met with this group of people and explained them, first of all, there were people who were new to Harlem telling us they didn't want us there. We've been there for 22 years. So I told them, well, first of all, we've been here longer than you, so we probably have to leave first. And it's not the best thing to say to a Native American, we should leave. We've been through that a couple of times. And then, so a lot of it was confusion and exaggeration by a newspaper I won't mention. But really, the group we really had to talk to, which made sense, was a group called the Greater Harlem Coalition. They were concerned, they were confused. It happened very quickly, very, very quickly. It was like a conversation maybe, and the next you know, we're like, we're opening. Some of that was intentional because of the potential, people just couldn't hear what we were doing. So what we did is we opened our doors and we invited people in. And we wanted them to see what we're doing and how we're doing it. All of their perceptions and ideas of what it looked like was off, wrong, off. It's a blessing to say, and there's a piece on WCBS put out a couple of weeks ago. You'll hear the chair of the Greater Harlem Coalition talk about how great we are. And I reminded them again about their request for us to open because of what they didn't want in the community. They're seeing the impact. There's a park across the street from our Washington Heights site where we partner with the Parks Department. They collect 13,000 syringes a month in that park, 13,000. Since we opened, that's down to 1,000. When people come in and use in our space, everything they use stays with us. So we are not allowing that paraphernalia to leave the building. So now that same community, and it's important to maintain an open dialogue. People are going to call with stories. People staged. We have people say, oh, they open and it's not working. Look at this. And it had these neatly packed syringes with caps on them. And users, no one sat there and did that. But we were prepared for it and we talked about it. A big thing in the beginning, especially, is to educate people. People are confused and people are scared. And it's important to respect that. Sounds pretty wild what we're doing. But we're saving lives. That's what matters.
And what have the results of this been? And I'll kind of reach out to you, Dr. Wolfe, in a way. I think preliminary results show that these types of things decrease overdose deaths, decrease volume in the emergency department, decrease cost. At least that's what's been shown in Europe, Australia, and Canada. So what do you think this might have an impact on state funding? I'll reach out to you, Pat, too, with this, but we only have so much money to go around. So how do you think this would impact what we have?
Well, part of the problem in our system is that the money saved comes out of different pots. And so where you save it won't necessarily go into being used in where we want it to be. It's just like the funds that are coming in from the opioid settlement funds in the past have gone to general funds with the smoking stuff. And so it doesn't go where you need it to go. I would say as has been said, this is logical. It's a common sense approach. The problem is you still have, I think, a lot of the enabling feeling in people, including medical professionals. I would say that when I started the Suboxone program with the help of Demas, there was a moderate amount of pushback from my group and other people in the department. Over time, that was a lot better. And people saw the utility of giving Narcan, giving Mark Jenkins with Demas gave us harm reduction kits. I think some physicians had a lot of problem giving out needles. And so I said to the nurses, you don't need your permission from the physician. You can just give it out. The physician has to give permission for the Narcan, but not for the kits. And I also said, I want to know if somebody is being not wanting to help the patient, and then we would have a little discussion. But, I respect a practitioner's right to have concerns. And so that's okay, which is why I said to the nurses, if you don't have a problem, then if the physician doesn't want to give the kit, you just can't get the Narcan. So I think that's a big hurdle, and that's the lay public feels the same way. And I think that's the battle you had as well. I think it's surmountable, especially in this state. I can't necessarily talk for other states that are anti-gun laws as well. But But I think that that this is a progressive state, and I'm cautiously optimistic that we can do it. I think we have to get through a lot of the red tape. Demas is a very easy entity to work with as opposed to some other state agencies. But I think it is doable, and the not in my backyard is always a problem. But I think, the problem also is that some of the literature that's out there is very embryonic, and it's hard to do real scientific papers on that. So, there's pushback there, but I think it's clear that this concept works, and we just have to expand it.
As a department chair, how do you think hospital executive team would feel about this concept? Would it have any impact on hospitals at all, good or bad?
I think it'll have a big impact on the hospitals. I don't, in terms of their involvement, maybe a whole different ballgame because of liability and all that they may not want to touch that. But the concept and what the benefit to the ER, to the police department, to EMS, I think is, as you've said, is self-evident. I don't think there'll be a pushback from the hospitals, but I don't know how much, they'll get involved directly.
Yeah, I think they'll be supportive bystanders at best, and certainly not on their land. I think that will be, but I really do feel like I'm trying to think over the last 2 or 3 years, and Stephen, you've been through this too, like 3 placement community issues that we had for opening up sites. And in each of them, we were able to turn it around, primarily by bringing people in recovery or family members of people in recovery who looked just like them and said, if this had been here, maybe my daughter wouldn't have X, Y, or Z. So that was very helpful. But this is a different concept. This is a whole different, I think of a recent suit in Cromwell about a group home and I did the expert witness work, so I'm familiar with it. And the feeling in that community was striking. And I was actually surprised by how vehement it was. So I think we have pockets of acceptance and pockets where it's just going to be an uphill battle. And I wanted to say, start with the state agencies because they're in the urban hubs, go to the state LMHAs and have them start to do this. But then I thought, actually, the private nonprofits are probably in better positions to do it. Although I guess the other question is, should it be connected to providers? Should somebody who's providing treatment also be doing this? I have no idea what the right answer is to that, by the way. It's just a question that I thought of a few minutes ago.
Are there ways for us to do questions?
There is. We're doing some questions here on site, but we will open it up to.
Yeah, we're going to have questions on site. We will open it up to the folks on Zoom. And actually, with that being said, I'm just going to pass around a 10. If you're not comfortable with reading your question aloud, you can just drop your note card in here and we'll take those back as well.
Thank you. Just a couple of questions. One is when an individual comes in, a client comes in, do you have them sign a consent form and a waiver? And then the second part is, do we look at this as a journey to recovery? And this is step 1 of recognition and acceptance within a community. And does that improve the likelihood of that person taking the next step? And do we have any insight or at least qualitative insight on that?
So the first question is, yes, they sign a form. It also goes as far as saying, if you overdose and you're in danger, you're authorizing us to respond to the overdose. Basically save your life. No, we do not. In harm reduction, one of the things that push people away is the conversation or the pushing of recovery. Of course, they come in and they meet half the staff who are in recovery, right? They meet staff members who have lived experience in a variety of ways. So it's not a conversation we have. Now, if they want to have that conversation, we're ready to have it. They're seeking any kind of treatment, we're ready to have it. Harm reduction is really about meeting that, truly meeting, not the cliche, but truly meeting the person in that moment and working with them in that moment to see where they go next. Now they know we're connected to treatment providers and detox and everything else. I will remind folks, 100% of our participants who utilize our safe consumption sites have all been in detox and treatment. We're not saying it doesn't work. What we're saying is we're aware that for many people, not everyone, it takes a multiple attempts before they get through it. So we keep that door open. And again, what we realize when we've seen harm reduction organization push recovery on people, it scares them away. And so it's there, it's alive. Like I said, we have so many staff members who are in recovery, identify as recovery. I had somebody celebrating 29 years today. So it's present. What was the next one?
I think you've answered both of them pretty much. The first one was, of course, the waiver, and the second one was, is the likelihood of recovery better?
Now that's different. Yes, definitely.
Yeah.
Definitely. The likelihood is better because it's not pushed on them. They're not, see, in New York, I'll speak for New York, and I don't think it's only New York, but many people who go to treatment are mandated to treat. They're forced into treatment. If they don't go to treatment, they go into prison. So we have numbers where people do fairly well, but they're mandated. So it's hard to measure. Is that true success? I'm not caught up in that. But so for us, it's that likelihood. We're seeing a reduction in the room simply because people want to talk to each other. I thank Will Smith for smacking Chris Rock because, and I mean this, it sounds crazy, but we had so many conversations in the room about that people were like, I'm not going to use this second bag. I want to give you my opinion as to why he did it. And I thank the playoffs and I thank baseball for starting. I'm serious. In that room, there's a community building. Staff members are part of that family. Sounds like recovery, doesn't it? Staff members are part of that process. I have 4 girlfriends now who, when they first came in, they didn't want to look in the mirror. These big mirrors with lights. They were like, oh my God, I'm ugly. I don't want to look at myself. And now I'm their boyfriend and they want to put makeup on in front of me. That's change. That's moving in the right direction. That's seeing the beauty in themselves. To me, that is engaging in recovery. They're on their way. I don't want to cry, so I'll be careful. So I'll just say a couple of quick things. My favorite, and I hope people hear this, compliment has been, we forgot you were open. So all these perceptions about crowds in front, they compared us to methadone programs, not talking bad about methadone programs. But if you go and speak again in New York City, you're in front of a methadone program, 30 people, a lot of people out front. We don't have that. And we intentionally make sure we go out and police that ourselves as well. And I'll give you our recent numbers if you're interested.
I just want to piggyback on the concept of not pushing people into recovery. The reality is that not everyone who uses drugs has a substance use disorder. And for a lot of folks, the systems that we've created cause the chaos that is then attributed to their drug use, where if we can get them engaged in community, and if they have a safe place where they don't have to hurry up with their use, or they don't have to do it in secret, they can still stabilize and be productive members of their community, whether or not they ever achieve abstinence or want abstinence. And I think that's unfortunately often overlooked.
One of the
things that comes to mind for me, because I am involved with the workforce for the last 12 years, not so much a client work, but with the workforce, is the NIMBY issue in the community is huge, and how we deal with that. You get more flies with honey than you do with vinegar. But the issue for me that I see is we've got to get the workforce on board, because we've got people in 2 camps that this is abstinence only, or then we approve, we're much more open to other parts. And I think that we have this issue in the workforce that we have to address, and really try to encourage people, to challenge people to look at their opinions and say, just be open to something you disagree with and learn more. And I think that's something that we as a field need to police ourselves with, that what are our staff telling clients? What are they telling their neighbors? What are they telling their friends about what we do? To me, that's a very, very big issue, because I deal with it every day.
I think one of the big successes in Connecticut in response to that, though, is having recovery coaches in emergency departments, right? Because they're talking to professionals
And what I hear is, professionals didn't want them there at first, and then after about a month, they're sidling up to them, telling them about their family member with a substance use disorder, and now they're widely accepted, and they're educating our professionals. I just see this as such a huge part of our solution, including the workforce issue. I think peer recovery support specialists can help us staff our agencies and hospitals.
Yeah, with the Suboxone program, we got the counselors in right away. Our department already had a very good social work department within, and so we got the peers we used as an overlay. So some departments used them to find treatment. We didn't use them for that. That was our job. It was really to connect with the patient. And if the patient was overdosed and wanted to, was given Narcan and then jumped off the stretcher and wanted to leave, we tried to get them. We brought in the peer immediately or as quick as we could, so that there could be a connection to try to keep them in the department. But we found a lot of success with that. And we had nurses also that followed the patients. So the peers followed the patients after they left the ED, but also our nurses stayed connected. There were 2 nurses that were calling and connecting with the patients and would bring patients back. And it was a very nice symbiotic relationship.
I think the value of the peers is immeasurable. We have to make sure that our agencies are allowing them to do what they're trained and skilled at, instead of being the filer, the driver, the urinalysis sample person. Everybody's got to do a little bit of that, but let the peers skills, ability,
I think another part of the solution is that we need to talk about it earlier, because I'm in college, and when I say the word safe injection site or something like that, none of my friends know what that is. And I live in Maryland, and Maryland is very hard hit by the overdose epidemic. And so my friends who live in counties that have thousands of overdose deaths every year have no idea what harm reduction strategies are. And I think this is an issue overall, because the say no to drugs is still being taught in schools. I've been taught that my whole life. I didn't even know that there was an epidemic going on until I was most way through middle school. And so I think that if we start talking about it and educating, our kids and educating people beyond just in the fields, because if you're just talking to other people in the field, you're not going to get very far unless you start bringing other community members into it and start talking to the next generation, so that, they're able to push for this change because they know what's happening and they want to do something to solve it.
All right, off of that, do you just want to welcome Nikki Bell? She's a former patient of ours from New Britain who was successfully discharged at the end of last year. So a little round of applause for her first of all. We appreciate her being here tonight. So we'll get to her in just one moment. I do want to address, we do have the folks on Zoom who are patiently waiting to ask their questions as well. One of them coming in here, we have a large amount of scientific backing on safe consumption spaces that are from other countries that have implemented them. It's just difficult to get in the United States since we now have just one state that has legal sites. How would that look? What would providers of MAT services working in these sites look like? With clinics knocking people down or off their medications, how would that look if we have someone who's utilizing substances while utilizing MAT? We know 25 of methadone doesn't touch fentanyl withdrawal. So with that increase, how do we wrap around folks and ensure their privacy and safety? Recovery coaches are not always harm reduction oriented.
I think that is.
I swear that one wasn't my fault. That's a lot. But we're hearing from Zoom for the first time, so digest that as you may.
I think there is a little bit of a problem with that with the recovery coaches, and I think we've got to address it just like we have to address it with our staff. And if you talk to people who are training recovery coaches, I think they're clear that part of the training is there are multiple pathways to recovery. There is not just one way, but just like clinicians, you're going to get people who have different opinions.
Go ahead. In terms of MAT, it pains me that there are providers who still kick people off the program because of other drug use. I don't see how that helps save lives at all. So I think harm reduction has to be woven throughout the continuum of care and really looking at, is this person at more risk by us continuing to treat or by us ceasing treatment? And if they're still using cocaine from time to time, but they've been stable on their opioid use, maybe that's enough for their recovery. And there was another piece of that that I wanted to speak to, and I already forgot the question. Nope, gone.
We'll come back. We have time.
I'll just add that we offer Suboxone. We have that program within our program. And it's going really well.
That reminded me. Thank you, Sam. The fact that methadone is not touching fentanyl in any meaningful way is a huge, huge problem that we're seeing. And in Rhode Island, we're seeing a ramping up of Black and brown overdoses. And that really aligns with the traditional model where Black folks had access to methadone and white folks had access to Suboxone. So that's where clinics were located versus your doctor's offices. So I think there's a lot to be, unpacked there, for lack of a better term, and to really prioritize who are the most at-risk populations now and how can we get them linked up with the most effective services.
Yeah, so Nikki, thanks for joining us. I'm going to turn the spotlight over to you. So question I had for you is, when you were kind of in the throes of addiction, I know you've successfully graduated our program, but is something like a safe consumption site or a safe injection site something that would have been helpful for you or for any of your friends or family members?
I don't believe at the time it was, I don't believe at the time it was really necessary. In fact, while I was using it, I still would have been like, oh, absolutely not. It's now that I'm clean, I'm a parent, and this world has changed. Like I didn't get into the fentanyl. I like to say the drug I used to do doesn't exist anymore. That's what I put in the back of my head. But I genuinely believe that this is a problem. Like I've seen articles in the news about, our fast track buses and needles and this and that. And like, I've seen it now, what I saw with my own eyes, and my kids were in the car and then I was like, okay. And then I started doing the research. And I think it's absolutely necessary. It's absolutely necessary all the way across now. At the time, was that what I needed? No, it wasn't. That would have given me an excuse. So, but times have changed and things have changed. This was 7 years ago.
But you were in a different place in your recovery, but for folks that might not be at the same stage that you are, what do you think?
I think now it's absolutely necessary. Then, no. I think 7, 8 years ago, the options were what they were. And I think that they were like that for a reason. Now it is far beyond anything I've ever seen. It's touching families and lives that at most times are unexpected. And I learned a lot in recovery, and I've seen a lot of heartbreak and a lot more recently. Some things have changed. I think this is going to be positive.
I think one thing is that today is so much more dangerous than it ever was before. And I can tell you as a paramedic in Hartford, I mentioned that the fast track. A lot of people take the fast track into Hartford, they buy drugs on Park Street, and then they use at the station. And sometimes there's a harm reduction group that's out there doing needle exchange, and people will go and use within their site. As a paramedic, I've had people come up to me and use within my site because they feel safe. You need to have that safety. People will die if they use alone and they get a bad batch of fentanyl. So with our bad bag, it's no longer bad batches anymore. It's any bag can be bad. But it's really, we have to do anything possible to keep people along.
In Maryland, we have something called the Good Samaritan Law, where basically you can, if you're using drugs or you see somebody using drugs and they overdose and you call 911, neither of you are going to be federally prosecuted. And I think that that's like, yeah, I think that's so important. And I would hope that every state has that.
We're working to expand ours because we found that law enforcement found a lot of loopholes in that. If it turned out not to be an overdose, it was a heart attack, arrest. If it turned out you had a warrant, that was a carve out. So there's legislation this year that would create protections for any medical emergency and would expand into possession as well as intent, so that folks have no pause in calling 911.
Well, that's actually another positive, I think, for this state is that we have teams now in many, in fact, in Manchester, where if you walk into the police station, they'll help you get into detox rather than arrest you. And if you overdose, they'll help you connect instead of arresting you. I mean, that's a
I think there is a carve out for that.
yes, you're probably right.
So we worked around that by having our fire stations be the safe stations to present and get services.
That's a good idea.
Yeah,
Warrants,
Rhode
if
Island,
they
we're
have
little, but we're
outstanding
powerful.
warrants. It's because you have cat power.
It's
So anything else from the group? Amy.
Well, one question for you in Rhode Island is how long do you think the process will be until you are able to open a site?
not soon enough. We're currently, we and our partners who are a fully harm reduction organization, so it's a nice balance of our two specialties. We're in the process of property shopping right now. It's a really challenging time, which is frustrating because we worked so hard to get here. But in addition to the property market being really terrible, the entire Providence City Council is going to see a turnover like we haven't seen in its existence this fall. So there's a lot of, if we get the property in August, this council person will be very much on board and championing it. If it falls to October, what does that look like? So it is certainly our goal to have it open sooner than later. Most of it will come down to where the property is. And if it falls in the ward of that person who said, yes, please, in my ward, she is sticking around. So a lot of it is contingent just on the purchase right now.
Good luck.
Thank you.
On second, sorry, Margot. Another question is, or maybe comment, blame it on being a social worker, but we've used so many different language is so important to me. And we have so many different words, you know, safe injection site, safer injection site, safe consumption site, overdose prevention center, which is my favorite one. Do you think, I think, and maybe this is the question is, do we think that we should really be coming up with a name that we use that is less discriminatory, less stigmatizing, that people can process easier? I think when I hear safe injection site or safer injection site, people are going to be thinking about injections. Right. So the consumption word is helpful, and overdose prevention, I think, is even
it's
a great word. But where do we land on? How do we land on something?
I mean, I did it up here myself, OPC, and I said safe consumption site. Safe consumption site specifically because people don't own insurance. It's very important to clarify that. So I'm open to, I think we should all be open to the words. The one thing I'll say about having people feel good, the number one medicine we've used is bringing people in and seeing it. To walk in the room, can you imagine it? When our last huge visit from some very important people, we had a pretty intense overdose happen. Mother came in, and I'm telling them this isn't staged, I promise you. One of them was a doctor, commissioner of health in New York City. He's like, this is hard for me not to jump in and try to help. And he watched a peer save someone's life. He was trained to respond like an RN. And what it did was the complete opposite. He was completely broken. He asked the person, what's your education? How did this happen? Oh, I just stopped using a month ago. I work here. I'm on Mac. I learned, I'm working here for a while. So a couple of very quick things I need to say. When you open your safe consumption site, all staff who work in the actual room should opt in. So we made it very important that in order to work in that room, you have to want to work in that room. You didn't just say you're a harm reduction specialist, you now report to that room. You have to want to be in that room. You have to want to be trained to work in that room. When you're selected to work in that room, you have to shadow for about 2 weeks. You can't do anything. You can only watch, even though you probably reversed, 50 overdoses in your career, in that room, you have to wait. It's very different. We're getting to an overdose when it starts. We're only using Narcan 15 to 20% of the time. We never use for the nasal Narcan, never. It is not good in a room like that. People are going to withdraw, they're not going to want to come back. We need them to come back. We need them to come back and know they're safe to use in that room. Anybody who uses drugs knows what I'm talking about. You paid money to get high, you came in the room. Although we saved your life, you withdraw, you're sick, you feel like crap. I'm not going back there, but they saved your life. I don't care. And that's what proves that we're not enabling people, right? So we're using intramuscular Narcan, 0.5 at the max. We're using oxygen all the time. This is what happens too. When organizations come see and visit, they realize, oh my God, this is nothing what I thought. I thought the person overdosed, you take out your nasal, you hit them a bunch of times, and then you wait for them to get up, and not at all. It's very, very different experience. I went a little extra, but I thought it was important to cover that. I didn't want to miss that.
Do you have policies and procedures, and then there's a chain of custody of the material or the drugs that people bring in, make sure that it stays with the right person, like fentanyl strip and then heroin check as well, and then appropriate usage? And do you have a defibrillator in the place? And
so we have a crash cart, defibrillator, pulse oximeter, and we have everything. Basically, every staff member is walking around. So you have a person called the RPIC, not so fancy, responsible person in charge. RPIC sounds so much better.
You're right.
That person's coordinating everything. So they're watching, they see an overdose stuff, they might send them a check. They check them, okay? It's an overdose. That person then takes control. It's the timer going, oxygen, how much oxygen in there, what's happening with their heart rate. They start controlling everything. They move the person, move around, get the tip, called a tip back. There's the intramuscular shot of Narcan. Get that ready, everything's moving. At that point, we're monitoring oxygen. No oxygen to the brain, you know it's better than me. We have to remove that opioid from the brain, which is why we don't hit them with 4 milligrams of nasal Narcan. It's just too much, and you don't need it. We haven't used it once, 324 overdose interventions. So at that point, we're still not using Narcan. We're moving them, we're agitating, behind the knees, Achilles, chest, we're doing all that work and talking to them. We get a response, we stop. We give oxygen right away. We don't get a response, we go to oxygen. We don't get a response, we go to a tip back shot. The crash cart came over. In the interim, the crash cart was pulled in. So all of that is happening in that moment when someone overdoses. And so there's a person in charge of the whole thing. We're monitoring it, writing down everything that happened when it happened. The person comes back and the person looks at us and goes, what happened? Just a minute ago, I was talking to you. No, it was like 8 minutes. Feels like 2 hours to us. But it was like a minute or two, and they don't even know they overdosed. But we're getting to the overdose so early. There's no reason to use 4 milligrams of nasal Narcan. It just isn't. So we're at the overdose the minute it happens.
And do you have predicted ratios that are acceptable? In other words, if you have enough helpers, then you can actually say, well, now we can't take any more in right now.
Oh, yeah. So we have booths where people inject and sniff, and we have smoking rooms. So, and I'm really glad, I'm sorry I don't know your name, but I heard what you said, they have time. We're not rushing people in and out. It's very important for people to have time to use and take their time. If we get a line, then we try to move it a little faster. We have relationships with our people. So we'll say to somebody, come on, I know you're just sitting here playing on your phone. Do you mind going to our drop-in center upstairs to get an acupuncture treatment or something? So now back to the policy and procedure. You weren't here when I said in the beginning. We've received many, many calls. Can I have your policy and procedure? I'm almost close to saying hell no, unless you visit and spend time, because I'm seriously worried about someone taking our policy and procedure and thinking it's enough to open. It is, I'm telling you, we're learning every day. And I opened a site with KNC, who ran sites in Canada. She's our senior director of programs. And we're still learning stuff. We took a lot of their lessons, of course, and implemented them. But it's not just, and I know you're not saying this, in general, it's just not a policy and procedure. This isn't like changing a light bulb in a car. This is deep and many, many lessons learned. So we're actually in the process of trying to get a grant so we could provide TA, spend time with people who are opening. If an organization can't afford it, we're still going to do it because we want you to open and facilitate this as well, in the healthiest way possible.
And Sam, I know we're on a lot of the DPA calls nationally. So one of the great things about this work is that it is so collaborative. So we've got sites who are already open, sites who expect to be next, sites who are starting the process, and they're all sharing their experiences. And I love your park needle pickup story. I used it today, talking to a politician. But it really is, Vancouver has been a resource for us and Toronto has been a resource for us, and we don't have to reinvent the wheel, and we don't have time to, obviously. So we're stalking New York very closely and planning to visit as soon as we can get our act together. But yeah, the partnership is really, really benefiting the whole country.
Just one thing very quickly, I forgot to mention, I wrote it down, NYPD. And it's important that if you're opening, what's your relationship with the police department? We try to get the commissioner involved. It was like, that's a little too much for me to say something. So we work with the local precincts in New York. We have precincts. We work with the 2 precincts in the 2 communities we're in. It is so amazing, this partnership, that a couple of times I'm driving in and I see a police officer walking with our participants. I'm trying to park quickly. New York is not easy to go find out where they're taking him. And the police officer was escorting him to our site, to use in our site. Said they were using it in a park. I told them, come inside. They asked us to create these cards because for years they were arresting folks using. So they asked us to create a card that says who we are, what we're doing. And the police officer walks over and says, I'm not going to arrest you. I want to give you this and don't use out here. Go inside where it's safe. Don't use alone. Go inside and go to a place that's going to keep you alive and safe. And there's all the services involved. The first person they brought in stopped the second time they came. They said, I don't want to even use. And I think we hired them like a week ago. So it's really about that too. And don't forget harm reduction. We don't demand that people don't use. We don't demand abstinence. But it's an environment, a supportive environment that people tend to get where they need to get when they're ready. And I like to say, anybody who thinks they themselves stop someone from using needs a checkup.
Do you have any data? Just curious on how many repeat overdoses you guys have had?
Yes, but I'm not even tell you that.
No, because you said, when the people wake up and they are, in a mood where they don't remember, they're not aware that happened. Are they inclined at all to make further progress in their recovery or maybe make some adjustments? Or how often are you seeing maybe the same people who are getting into these situations?
We have a number of people who've been using a very, very long time. I mean, 30 years, long time, who to them, that's part of the process. I think, sorry, I don't remember your name. When you came in and talked about how it's different, it's very different, But as I said, we're testing heroin to see if it has heroin. Like it just doesn't. So you have people who, this is a huge part of their life. Like this is who they are. So when they come back and we tell them you relapsed, they're so far here. Like I'm expecting to die, but we're watching that change. We're watching people feel better about that. I'll tell you this, we have 1,300 people participating in 6 months. Of those 1,300, we have 22,000 utilizations. So people come back a lot. Don't forget, if you're using fentanyl, you're likely to speedball because it's so strong. You need something else. You need a stimulant to even function in a sense. So we're 1,300 people, over 22,000 visits. We're only open 5 days a week in Harlem and 7 days a week in the Heights, but we close every night. We know that when we're going in 3 phases. Next phase is to 11 p.m., 7 a.m. to 11 p.m. And then the third phase is 24 hours. We know those numbers are going to increase tremendously. And with that, we're at coming up on 330 overdose interventions. The city hoped to open 4 and have 130 interventions. We have 2, and in 6 months, we have 330 interventions because of fentanyl and because of what's out there. Imagine taking cocaine, expecting a high and overdosing on fentanyl. It's the reality for people. Yeah, then I could retire. Yes, I agree.
Any reactions? We have a few counselors here. Anyone else from the group? Questions for our panel?
I can just add one comment on, you've asked about common language. Mark Jenkins, it's a shame he's not here tonight, but he has started a group in Connecticut, the Connecticut Action Alliance, I think he's calling it. And one of the main goals of it is to get a common language to be used across the state. And I think overdose prevention site might be what they're leaning to, but that's something that they're really working on. It's important to have the proper language.
Exactly from what you said.
Yeah.
Because if everybody's talking about purposes, it confuses, with all due respect, the legislators.
I'll add something, when I hear people talk about looking for sites, it makes me a little nervous, only because the strength in our program is the co-location of other services. I don't have to take someone somewhere else. I'm actually seriously looking into opening a detox. So that when someone wants to detox, they can go right upstairs or right across the street very, very quickly. I believe people knowing a detox is there will say, I just go upstairs and I'm in. We'll change that. Insight in Canada has that. But yeah, the co-location of other services. Example, I keep the radio on in my office. It's not Big Brother. I'm actually excited hearing everything happening in the room because everything's done through radio. And to hear case manager now, someone wants to go to detox from the OPC, I'm doing it again, from the safe consumption group. Someone wants to go to detox. That's quick, let's go. Case manager goes down and gets it done. So having those services, someone wants an acupuncture treatment, they came out of an overdose and they want to detox from their body. Because auricular acupuncture helps with detoxification. So they might want to do that. All those options right there. They can see the doctor after an overdose. They can see a nurse after an overdose. If they have a wound, we have wound care on site. So all of that is happening in one space. So if you're looking for a site, please, my suggestion is that you try as much as possible to have services co-located. So it's streamlined. It doesn't seem like now I have to travel somewhere else. You don't have to have everything we have. Maybe you can get more different, your people. But I would try as much as possible to have co-located. I have people tell me, I get it now, this is great, but can you open it under the bridge? Literally, can you open it under the bridge over there, that place where nobody is? And the answer is no, because I want people to have access to services when they need it.
I want to add something. I just want to say it as somebody in recovery. You can make a building, you can have a site. It's about how you make the people feel. And until somebody feels like, oh, that's not a place where they're just keeping an eye on me. Because, drugs make you paranoid, guys. It's great to you. Okay. Not only, I'm guilty. I was in the car like, what's going on? There's nothing going on. No, it was me in the parking lot. Just being weird. But legitimately, it's not, that's the problem now. That's the problem now. Everybody thinks a clinic, oh, they hear clinic, it's over, But you guys change. It's root. People hear root and it's out there and it's becoming more noticeable. But at the same time, we want to see people that are going to care, because a lot of times those people that are going to walk through the door are the people like me who are sitting in their car alone. You know what I mean? Because they didn't have a family, or they didn't trust their friends, or they didn't even care. But part of them did. Somebody dropped that hint 4 years before, and they remembered that during the paranoia, and now they want to go somewhere. But we got to make sure that one time is not their last time.
And now, Nikki, you had been successfully discharged from our new brain clinic, which is our newest clinic, state of the art. You can testify to how beautiful it is and how it really is supposed to make our patients feel well respected. To go off of that and also to weigh in with you, do you see folks change their demeanor when they come to your sites, as we've seen kind of a shift in the personality and the way people hold themselves when they come into our new brain clinic? How are the people who come to your site? Do they feel more respected? Can you see them maybe making other positive changes in their lives, even though they may still be using, that this site maybe gives them some type of respect from the community?
That's an excellent question. Yeah, it's their site. We tell them it's their site. We built this for them. It's not our site. Kaylin C says, she's our senior director of programs, the least interesting thing that happens in the room is the drug use. release. The relationships, the conversations, the humanizing, dehumanized people, loving them until they're ready to love themselves.
That's what matters.
People walk in that room feeling like, that's my room. People thank us for building their room. It's theirs, which is why we don't have issues in front of the building, which is why they're policing each other. And if I go outside and say, look, you guys out here smoking cigarettes, you're going to cause traffic. It's not good for the block. They go out and say, don't do this. I need this place open. I need this right now. It's the only place, and I keep hearing, and thank you for saying that, don't use alone. It's a place people can use with someone who's going to keep them alive until they're ready. And we're watching people get ready and feel better about themselves. So thank you for that question. It's their space. It was built for them. They run it in a sense, we listen to them. They've come up with ideas. We've implemented them. We have a cab that includes members of that room and people who use. So it's truly their space. Thank you.
I want to thank you for what you're doing. And I'm not sure if you mentioned how long you've actually been open, so I'm sorry if I missed that.
So we opened November 30th. And it was interesting when you talked about someone coming and someone leaving. We opened November 30th of last year. De Blasio was the mayor, and he was leaving in a month, in literally 30 days. And so the risk there was we opened under him, and now we have a new mayor who was a former police officer. So I also wouldn't have opened if I wouldn't have gotten his blessing before that. So we knew coming in, he supported us. He supported what we were doing. So we knew we wouldn't have to open for 30 days and close. So yeah, November 30, 6 months.
And so in those 6 months, you've helped 1,300 people.
1,300 people using the space. We help their families. We help their loved ones, because it's not only them. One of the things we see, a couple of people have reunited with their children. They're getting visiting rights again. They're on their way back to building that, which indirectly, there have been many unintended benefits of opening this, that why collecting data, and thank you for mentioning the research we're doing. We're doing one with NYU. There's a number of big ones coming out. We also collect a ton of that, which we will be putting out soon. One of our staff, Brent Gibson, the amazing Brent Gibson, created an app called the Send app, which we want to share with people when they open their program. Someone comes in, we give them a barcode, they can put on their keys, their phone, whatever that is. They come over, they scan the barcode. That's all they have to do. And we know they took a shower. Oh, by the way, sorry, forgot to mention that. We have showers, we wash people's clothing. We offer all of that free. So someone comes in, they had coffee, they had a meal, they took a shower, they did, all of that is being collected. And the staff are so happy that they're not writing all that down. But yes, it's been 6 months, 1,300 individuals using the safe consumption site itself, almost 23,000 times, and almost 330 interventions, and it's kept people alive.
No, well, thank you. It's amazing. I travel New England and New York, and I have found that it's been really difficult working with providers to get past the stigma, to just be real with people and help them. And so it's just really lovely to sit here with you and to hear what you're doing for people. Thank you.
I happen to have the best staff on the planet. No offense for those who work here. I never get to get involved in an overdose. There's a joke, by the time I get there, it's already done. I'm always late. I will say, before we opened, we had an overdose in the office one night, and they asked me to get the oxygen. And I went twice and picked up the oxygen we used for training, which meant it had no oxygen. So they stopped asking. When is what?
When's Brooklyn happening?
Brooklyn's closed because there are a couple of organizations wanting to open in Brooklyn. We have a couple of partners there like Vocal who are close. We're getting closer and closer. We're excited about it. Not us, but another org opening. There are some people around the country really close. I wish I could say I'm excited. I'm traveling out to a few places to support them as they get closer.
We do have a Zoom question. Courtney would like to speak. So I don't know if Courtney can unmute herself earlier. We could hear through there. If not, I'll try and
I can.
Oh, okay, perfect. We've got Courtney. All right, Courtney, go ahead.
Hi. I'm sorry. This is going to be a lot because I've been sitting on Zoom listening to this entire conversation and building up a bunch of questions. For those who don't know me, I'm actually Canadian. I've been here since 2018. The year before I moved here, I was actually involved in a grassroots overdose prevention site that a group of volunteers operated while the city was still figuring out the logistics for brick and mortar sites. So basically, we saw the need in our community and we met the need, very much similar to Moss Parks in Toronto. I can say from firsthand experience that overdose prevention sites or supervised consumption sites work. Our current sites back home also offer on-site drug checking, which is something that as an agency here in Connecticut, we are working on doing. I can also say that the fears about sites increasing substance use or violence or crime in the community are absolutely incorrect. I would also like to echo my coworkers' previous concerns about treatment program providers collaborating with safer consumption sites. I am interested in what planning will there be regarding protecting site participants, knowing that medication is often decreased due to someone's active substance use. How are we going to protect the information that is shared between sites so that someone accessing a consumption site isn't putting their treatment and medication at risk? I use the word medication for a reason. And then also with the toxic drug supply, and I feel that we've left xylazine out of this conversation. If we're looking at establishing safer consumption sites, are we also including conversations around safe supply? So back home, we have managed opioid programs where folks who have been through traditional treatment programs multiple times, that's not working for them. They're prescribed hydromorphone, which is Dilaudid, and they often go to an overdose prevention site to use their medication. It has had astonishing results. Folks are no longer concerned about overdosing, about having to get their next fix, and they're able to focus on other things in their lives.
I guess I'll start with, as a medication provider, we are very clear that use of these sites or ongoing use anywhere is not going to affect treatment. It will potentially have decision-making implications in terms of the risks of certain medication interactions, but we know currently there's a de facto consumption site around the corner from our building and our clients frequent it, and then they come back and they get their medication if it's safe to give it to them. So we will definitely be keeping this. The partnership that we have with Project Weber Renew will be semi-independent in the sense that you can easily access either additional services, but what is happening at the safe consumption is not part of the medical record, so to speak, in the treatment facility. I was super glad you brought up what's increasingly known as benzodope. If we don't start to push for safe supply now, we're going to miss our window of opportunity. Folks who had been using fentanyl, who could get like a Dilaudid or a prescription that would be for safer, predictable supply, can't be held on that if they are also dependent on the co-occurring benzodiazepine that's being mixed in. So that is an absolute priority. Rhode Island is having these conversations. And it's definitely a goal for maybe 2023 legislation, but we are definitely pushing for that.
Yeah, I think safe supply is something we absolutely have to be talking about as well. I mean, the safe consumption, overdose prevention states is great, but it goes hand in hand with decriminalization, safe supply, and ending the war on citizens, as Sam talked about. It's been a spectacular failure. It's done nothing but divide the country, put people in jail, and harm families. It's just clearly not working. So we need to be talking about these things. Just because somebody could say, oh, politically, we can't make that happen right now, we have to have the conversation. Very important. And as I said before, the safe supply is people are being killed because they cannot judge the dose. They don't know what's in it. It looks the same. And one $4 bag might have nothing in it, and the other $4 bag could kill an experienced user.
People are getting pills on the street and thinking that's safe, but that's all contaminated with or made with fentanyl, so they're overdosing. So it's certainly not any safer than getting a bag of heroin on the street, which is all fentanyl anyway.
Go ahead.
And I just wanted to say that it's
amazing that you guys offer showers and like wash people's clothes. Like that's a very basic need that a lot of places don't or aren't able to afford to the people that come to the door. So just the fact that that's even something you're able to do is incredible. And I'm sure it makes your people that come through feel very, very good about themselves. Just something as minimal as that is so major in people's lives. So I think that's amazing.
Yeah, it's definitely, we hear it all the time. It's nice. A nice hot shower. You know, for us, we take it for granted. Sometimes we're like, oh, I gotta take a damn shower before I leave the house. It's a big deal. Offering every time they also take a shower. Unfortunately, many of our people don't shower that often. We offer clean underwear, a whole new set, so that they feel really good about that while they're in there. We try to wash their clothes as well if we have the time, but we will wash the clothes. They may not have, so they might get a new outfit during that same time. We do get a lot of staff and other folks donating. But yeah, shower, wow. I've seen people look different even and just feel, you can see in their eyes, they feel supported in a way. It seems like it's not a big deal, but it's huge.
We used to have those in Connecticut, but the funding went away and they were terrific and they were just drop-in centers, right? People could walk in, take a shower, wash their clothes. I mean, it was incredible. And unfortunately, the funding.
Yeah, I will say LA, I was out in LA, homeless healthcare. They have two huge trailers, homes, the mobile homes. And one is for showers and one is washing machines and offices. And that's separate from their office. So it's kind of located. It's near, of course, it's near Skid Row. There's this one location and it's 24 hours a day. People going in and showering, washing clothes, washing clothes. We wash the clothes. We don't ask them to do it. It gets a little, could be messy and breaking machines. So we give them bags and we wash the clothes ourselves.
We've got mobile units that drive around to various spots, be they shelters or kind of congregate areas or encampments. And they're on a known schedule so that folks can just present, and it's called Shower to Empower. They offer services like that. It's obviously easier to do on the scope of Providence scale versus LA scale or New York scale, but we do have a lot of great community partners who work closely to make sure that if we don't provide a service, we know who does and we can get folks.
Nikki, I'd just like to ask you, as someone who's been, so gracious in opening up and telling a story that a lot of people may not be comfortable telling, how have you seen the world of addiction and recovery change since you really first got involved to where you are now? And sitting on a panel and hearing all these folks who are pro-recovery and anti-stigma and where the direction of recovery and addiction management is going, how does that make you feel knowing that you were successfully able to complete a program and now you're trying to inspire others? You've seen the changes in the last, 5-10 years. Explain to us a little bit about what that looks like from your side.
Okay. I used for a long time, like before that. So I kind of just evolved with it for a while and then things got out of control. But unfortunately, it's touched me in a heartbreaking way. Like just recently I lost a friend who I never thought I would lose from fentanyl and cocaine, and somebody left him there. So this is somebody very well-known, loved, so unexpected. Lost friends that were, had a cheerleading squad, graduated from their 4-year college. And this is far beyond anything. Like before, it was just like, oh, you are a bad person that does this and we're going to cut you off. No, this is everywhere now. It's not, it's out in the open. It's not hidden in songs. No, it's out there. And it's right in the forefront. It's not just in our cities, it's in our suburbs. First time I ever did a hard drug in my life was in a suburb. And I've seen it take a really nasty turn. If we don't embrace just what it is, and that is that we all need to be hands-on because it's everywhere. It's in our schools, And no, not just your high school, it's in every school. It's in elementary schools, whether it's, kids bringing it in their backpacks because that's all they know. Because we didn't, as a community, as friends, family, we chose to versus educate, and even if you're gonna cut somebody off, you have to really strong some education first and some direction. But honestly, this has become something I never thought it would be. And I saw my mother in addiction. I saw a lot of people, and this is touching everywhere. And if anybody's talking about stigma, it's right in your backyard. There's stigma. What? There shouldn't be any, because it's right here. It's everywhere. And if people don't know, pick up the paper, because that's just crazy to me. I apologize, but that's just nuts. But unfortunately, I removed myself from a lot of it, so I don't know hands-on too much anymore, but I know what I see, I know what I educate myself with, and I know that it is much different. It's a beast. It's a beast that needs to be controlled.
I think we really have to also, I can't be in the room, Stephen, and not say this. We have to move away from stigma and call it discrimination.
Thank you.
For God's sakes, it's discrimination. It's too easy for people when you say, oh, they're stigmatized. Well, that's easy to put up with. But if you say to somebody, you're discriminating, it's a lot more powerful. So language is so powerful. I really wish we would eliminate the word stigma.
Every day for 10 years straight.
I did.
I was just gonna ask, when did you start saying that? 'Cause I remember probably like 12 years ago, saying that and saying, if you don't show me output, don't ask me for input.
Yeah.
I think on the teaching part, I graduated high school 2 years ago, and I had never heard of fentanyl. So they're it's not talked about at all. And again, my state is not one of the, it's not doing great. And it's just not something that's discussed at all in any health classes or anything. And so until, I started doing my own research, I don't think that most of my friends, some of them come from Baltimore City, they don't know what fentanyl is. And so if somebody, decides to pop a pill at a party, they're not going to know what hit them because they just don't know what it is, because it's literally not talked about at all. And that's just really scary.
And no one will know how to respond.
Right.
Definitely not.
Go ahead.
So I just wanted to say, being someone that works directly in the field with individuals every day, I kept thinking today, as you guys are talking and saying a lot of the things that you said about meeting someone where they're at, right? Meeting someone where they're at is something that it's been ingrained in a lot of people's education, right? And even I remember back at school and everything like that. And I think that is something that we need to talk more about, in the treatment, with treatment providers, and at least say in Connecticut, right? I mean, we need to refocus on that and meeting individuals where they are at. That is so important. And just a lot of things you said tonight really kind of hit that for me. And I hope we can do a better job with that.
Yeah, so any questions from online? Or
No, Courtney did want to add though that there are some facilities that do offer showers and some offer laundry. It's just not statewide at this point.
Two questions, and this is from a selfish point of view as a legislator. With all the brain trust that is in this room, what are the legislative fixes that you think are needed? And the second thing is, are there organizations in Connecticut which are shovel ready, waiting for the laws to change?
I have no idea about the shovel ready. I have a feeling it's too early for that, but I think these kinds of forums will push us in that direction. Stephen, tell me if I'm wrong and you guys are ready to go, because
which organizations are shovel ready for this, waiting for the legislation to be started, and what are the legislative acts? I think
Samson, it sounds like Samson needs money. So Connecticut, as Pat said, is going to be a bit different. So from my perspective, it's sort of getting the go ahead from DPH, getting the go ahead from Demas. Okay, here's the licensing needs. What are they? No, there's no licensing needs, and then you're just talking about money. What was that?
if you want to get it done quickly.
Yeah.
No licensing needs and don't promulgate regulations.
Yeah, yeah.
It'll
So-
take
so-
10 years.
Yeah, so
Yeah.
Senator Anwar, this is just about money. I think there's more organizations that can do it. But when you're talking about the nonprofits also will need some funding. So I think that's the difficulty for a nonprofit to be able just to build one of these and eat 100% of the cost. It's very challenging, even if the regulations are none or you're allowed to. So I think that's going to be the challenge. I think that our organization has a bit of a luxury that many organizations don't have. And we have a board here that really supports us in some of our mission-focused work through our endowment, and we've moved forward on some initiatives just based upon that. But I think for the most part, 90% of the nonprofits in the state couldn't just go do this without having the funding support. Although I bet you 100% of them would want to.
And I guess the question that I'm still unclear about is, does the federal law preclude the state from funding something like this? I don't know enough about it.
No. I mean, I'm not going to talk about Connecticut. I'll say that what we're seeing happening in a number of states is the state itself, legislators saying, we're going to use language to get around some of that. Knowing still it's federally legal and marijuana is what people are following in that way.
And they're using the word pilot.
Right. Pilot is a big one. Pilot creates safety. If you get a research, if you get an NIH or something like that, you create safety. So people are doing a lot of that. The blessing is we've been successful. I don't say that in a bragging way. As I said, I haven't participated in any one of those 300 plus interventions. But yeah, pilot is big. People are moving in that direction. I wanted to say something else very quickly. It's important when you open one of these that every staff member and every board member, the board is at risk with, not the staff. The board, my board and I could be arrested, not staff. But every board member and every staff member participate in every life we save, one way or another. If you're inputting data, if you're head of our finance department, if you're part of our HR department, if you're the front desk person, I don't care what you're doing, you're participating in saving someone's life every day. So when we put these numbers out, we get to 200, then 300. I often send an email to all staff, thank you. Everybody playing a part in it, because you tend to start focusing on the folks who are working in the room, like they're the ones actually doing it, but they can't do it without everyone else being involved. And that really gets people to see this work very different, even those who are working with us.
We have another question from online. This one kind of goes back to the language that's used, and it's kind of the flip side of the coin here. Saying yes to language, I'd also like to take a moment to reflect on some of the language that's been used in this conversation. Relapsed, return to use, clean, active addiction, and the purpose of sites is connection, not to get people to the point of wanting treatment. Some folks won't ever want recovery. Some folks won't ever want to be in treatment, and we need to acknowledge that. So I think that's kind of the reverse of what we've been saying is obviously the goal is to get those people to that point, but acknowledging as well that that may not be possible, but there's still a huge benefit to having them.
I'll be clear, as a harm reduction organization, it's not our goal. Our goal is to address them in that moment where they are, what they need in that moment. Oftentimes, as people move towards recovery, they don't participate with us anymore. They move to another organization. They go up to our partners who are out there doing that work. Again, we don't even have things up on the wall that talk about it. It does create for active users, it creates a potential danger for them to think that's what you're going to try to get them to do. And if they don't, in their lives, if they don't say, I'm interested in recovery, in the courtroom, et cetera, then they're usually treated very differently. So I just want to say clearly, as a harm reduction organization, you haven't heard me say any of those words. One of my least favorite words is clean. I just, one of my least favorite words. When someone took a shower when they were using, they were, oh my God, do you? I like you even more. Oh my God, I like you even more. Wonderful.
It's a journey.
Wow. It's a journey, right? It's forever.
Yeah.
So yeah, I just wanted to be clear with that. And I totally agree with that. Language matters. I'm a linguist. Language really matters. which is why I'm very careful with certain things I say. Well, I say, and I'll tell you this, there's a story we talk about Mark. I won't give you the story, but I called him Mark and he cried for like an hour because no one's called him Mark. They called him junkie, dirty, bum. And I just said, Mark, I asked, what's his, his name is Mark. I'm like, yeah, I like that guy. Hey, Mark, how you doing? He turned around and I thought there was a problem. 6'3" guy starts crying like a baby. Because I called him Mark. Like, that's what we're working with. And that's the beginning for Mark to believe that people care about him. Who's in the right place.
We're going to do one last question for the night.
Thank you. And so, Alina, correct, right? When you were saying, you've said a few times, I didn't know, nobody told us. Well, and I wasn't going to say this today, but I'm going to, because I came here on behalf of Root. And thank you, Root, for having me be part of your partnership now. But what you might not know is there is an app out there that's FDA approved, that's free for people, that is harm reduction, that provides 24/7 access, that so many providers have stopped me from helping them give this to their patients because of, I don't know why, it's a mystery to me, but I feel that it's our responsibility. I'm an LCSW to let people know what's available. We have proof. We're the first FDA app that shows that we can increase retention when people have it on their phone. I want to give it to 1,300 people. I cover New York. I'm going to work with you. So these people can have this on their phone. Yes, thank you. I have
Is it
come
Brave,
to
by any
in
chance?
Rhode Island.
Is it Brave?
It's approved, FDA
Yeah.
approved. It's been approved for years.
Yeah.
Rhode Island, you even have codes that cover it, that can
But
create
it's the Brave
revenue.
app, that's what I'm asking.
It's
it
a what?
The Brave app?
No, it's called
Oh, okay.
Reset. We're Care Therapeutics. We're the first to create this ever in the United States. So anyways, it's exciting and it's available to people, right, that you work with. And so I don't know what else to do, but to say like, let's give it to people because it's available to them. It helps them. It's a tool and we need to work together. It's not the only tool, right? But we need more. We need more support. And so it's there. And I need your voice to let people know that they have this as an option on their phone.
Well, thank you. Yeah. One last comment from Dr. Anwar.
In the last many years in the intensive care unit, we have lost so many young people that anyone has any ideas, and there's one more people who are listening or would listen at some point. Anyone who has any ideas to not have individuals die is a good idea.
Thank you very much. It's a great way to
Good last
segue.
statement.
So I just want, I've learned so much from the panel that we have today. Some people came from very far away. So I just want to thank our panel. So thank you very much, everyone.
This video was brought to you by the Root Center for Advanced Recovery and our new Advanced Recovery Institute, where we're investing in research and training to elevate clinical care both at Root and across the country.